If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. Today we're looking at the new updated NICE guideline on type 2 diabetes in adults, always focusing on what is relevant in primary care only. The diabetes guideline is a comprehensive document, so I'm breaking it down into clear and practical sections. Today, we're focusing on insulin-based treatment and the management of complications. In recent episodes, we covered the earlier sections. Right, let's jump into it. First, let's look at insulin-based treatments. When we start insulin in adults with type 2 diabetes, we should provide a structured education. This education should cover aspects like injection technique, self-monitoring, dose titration, fitness to drive advice, managing hypoglycemia and managing acute changes in glucose. When initiating insulin, we should continue metformin in people already taking it. We should stop any other medicines used solely to manage hypoglycemia. And we should discuss the risks and benefits of continuing medicines that have other benefits, for example, cardiovascular protection or weight management. As initial insulin therapy, we should offer a basal insulin intended for once or twice daily use. If HbA1c is very high, especially 75 mmol per mole or 9% or higher, we should consider starting with basal insulin plus a short or rapid-acting insulin. This can be given as separate injections or as a pre-mixed biphasic insulin preparation. When choosing the insulin preparation, we should take into account whether the person needs help with injections, whether there is concern about nocturnal hypoglycemia, and whether once daily injections would be preferred. If more than one basal insulin type is equally suitable, we should choose the least expensive option. We should consider pre-mixed preparations that include insulin analogues rather than human insulin. If the person wants to inject immediately before meals, if hypoglycemia is a problem, or if glucose rises significantly after meals. At each review, we should check whether someone on basal insulin also needs bolus insulin before meals, or move to a pre-mixed biphasic regimen. At each review, if someone is on pre-mixed biphasic insulin and their targets are not met, we should check whether they need to switch to a different pre-mix or move to a basal bolus regimen. Now let's move to complications. At annual review, we should advise adults with type 2 diabetes that they are at higher risk of periodontitis. We should explain that treating periodontitis can improve blood glucose control and can reduce the risk of hyperglycemia. We should advise regular oral health reviews, and if periodontitis is diagnosed, we should offer dental appointments at a frequency based on their needs. We should think about gastroparesis in adults with erratic blood glucose control or unexplained bloating or vomiting while considering alternative diagnoses. If vomiting is caused by gastroparesis, we should explain that there is no strong evidence that antiemetic treatments are effective. Some people may benefit from domperidone, erythromycin or metoclopramide. We should be clear that domperidone has specific safety risks, particularly cardiac risk and drug interactions, so we need to prescribe cautiously. For treatment, we should consider alternating erythromycin and metoclopramide. We should only consider domperidone in exceptional circumstances, when it is the only effective option and in line with safety guidance. If gastroparesis is suspected, we should consider referral to a specialist service if the diagnosis is uncertain or vomiting is persistent or severe. For painful diabetic peripheral neuropathy, we should follow the relevant guideline. If someone loses their warning signs of hypoglycemia, we should think about autonomic dysfunction. We should also consider autonomic involvement of the gut in unexplained nocturnal diarrhea. If someone has autonomic neuropathy, we should be aware that orthostatic hypotension is more likely when taking antihypertensive medication. If someone has unexplained bladder emptying problems, We should investigate possible autonomic neuropathy affecting the bladder. Management should focus on the symptoms present, for example, interventions for abnormal sweating or nocturnal diarrhea. For prevention and management of diabetic foot problems, we should follow the Diabetic Foot Problem Guideline. As part of the annual review, we should offer to discuss erectile dysfunction when relevant, including addressing contributory factors such as cardiovascular disease and discussing treatment options. We should consider a phosphodiesterase 5 inhibitor and initially choose the option with the lowest acquisition cost, taking contraindications into account. If the treatment is unsuccessful, we should refer to services that can offer other medical, surgical or psychological options. In terms of eye disease, at diagnosis, we should refer adults immediately to the local eye screening service and encourage regular attendance. We should arrange emergency ophthalmology review for sudden loss of vision, rubeosis iridis, pre-retinal or vitreous hemorrhage, or retinal detachment. We should refer to ophthalmology in line with diabetic eye screening pathway standards and follow the Diabetic Retinopathy Guideline. In the Type 2 Diabetes Guideline, the recommendations on diagnosing and management hypertension have been removed. For hypertension in people with type 2 diabetes, we should follow the Hypertension in Adults guideline because management is broadly the same as for other people unless specified otherwise. Finally, we should offer antiplatelet therapy such as aspirin or clopidogrel for people with type 2 diabetes who do not have cardiovascular disease. For primary and secondary prevention of cardiovascular disease, we should follow the relevant cardiovascular disease and acute coronary syndromes guideline. So that is it, a review of a section of the NICE guideline on type 2 diabetes. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guideline. You must always use your clinical judgment. Thank you for listening and goodbye.